I think we will get started. All right. Good evening, everyone. Thank you so much for being with us tonight. We know you could be at dinner somewhere else, and we want to welcome you to our webinar. So in order to make full use of your time, we're going to get started. My name is Dr. Yemi Famiyiwa. I'm the founder and medical director of Montgomery Fertility Center. And with me tonight is Dr. David Pfennig, who is the director of Male Fertility and Microsurgery at Chesapeake Urology Associates. So in introduction for Dr. Pfennig, he completed a surgery and urology residency training at NYU. He also completed a fellowship at the country's leading program for male reproductive medicine and surgery at Baylor College of Medicine. The goal for tonight is to present an overview of male fertility, and the hope is that all participants will be able to have a better understanding of what male factor is, what the causes are, and how it's diagnosed and treated. So tonight we'll have two formats. The first format is we're going to listen to a wonderful lecture by Dr. Pfennig. The second format is going to be more interactive, where we'll entertain questions and also go into a little bit more about how the treatment for male fertility is oftentimes in collaboration with treatment for female fertility. The two go hand in hand. All questions should be asked in the question and answer box, and we will answer both live and also in the chat as well. Feel free to type any questions that you have. So without much further ado, I'm going to let Dr. Pfennig start.
Thank you for having me. Let me bring up my slides here. Can you see that?
Yes, you can see.
Let's see. Not. Let's see. Is it in the slide present format? Give me 1 second. Okay. Let's see. Looks like you can see the top of my bar, but I will get started. Thank you for having me. Good evening, everybody. Thank you for attending. Tonight I'm going to talk about the advances in the diagnosis and treatment of male infertility. This will be a broad overview. I could easily talk for hours, but we'll keep it nice and concise and leave time for questions at the end. So I am the director of male fertility, sexuality, and microsurgery at Chesapeake Urology Associates. My specialties are to the right. And then we should have poll 1 at this time.
Okay, so we're starting poll number 1. And if I could entertain answers of what you think you know about male fertility before we get started.
Yes.
Feel free to send in some answers.
Right. So how many people here are aware of or know about male infertility? Or here for male infertility, I should say.
Okay. I'm going to end the polling, and I'm going to share the results.
Okay. Okay, good. So the majority are aware and know something, and for those of you who don't, we will get into the conversation. So in order to evaluate couples, we typically get a semen analysis, which is obtained as part of the initial evaluation of the female partner, or if the patient is newly coming to me for male infertility, we'll get a semen analysis as well. It's really the easiest initial workup for both female and male partners. So all men with abnormal semen parameters or couples with unexplained infertility should be referred to a dedicated male infertility specialist. And of course, the goal is to achieve a successful pregnancy in as natural way as possible. In terms of the prevalence, about 6.1 million couples in the US have infertility. 1.2 million women per year make new office visits to the doctor for infertility. And of these infertile women, only 20% of partners receive a medical evaluation for male infertility. And the reason is, generally people always thought that the problem is usually due to the female partner, but we know that not to be true. And it's also true that many urologists are not well trained in male infertility. So poll number 2.
Okay, so launching poll number 2.
So what percentage of infertility is due to a male factor alone? Is it 10%, 30%, or 70%?
Oh, okay. All right, now I'm going to end polling and share the results.
Okay, 30%. Well, people know their statistics. Surprising. So this pie chart shows the distribution of infertility. And what we see is that 30% in the orange is due to a male factor alone, and 20% is due to combined male and female factors. So approximately 50% of the total is in part due to a male factor. In order to optimize male fertility services, these are some indications for referral to a male specialist. One is azoospermia, or no sperm in the ejaculate; oligospermia, which is a decreased sperm count; abnormalities of sperm motility or movement; unexplained infertility; pyospermia, which are increased white blood cells on the semen analysis; potential infections in the semen; past medical or surgical history with issues; and also comprehensive couple evaluation and counseling. For the evaluation of the male, we take a detailed history, both sexual and reproductive, ask about medical conditions, social factors. We do a physical examination. Laboratory evaluation involves a hormonal evaluation. Sometimes men need genetic testing. And then 2 semen analyses to demonstrate consistency. And there are also ancillary studies such as ultrasounds and occasionally a testis biopsy. So in terms of the sexual history, we have to know about the female partner as well. So does your partner have regular cycles? Does she know when she ovulates? Obviously, we want timed intercourse around the time of ovulation, and use a lubricant. Many lubricants are toxic to sperm, and so this needs to be inquired about. This just shows some ovulation detection kits. Many people use basal body temperature or chart things on apps. So as far as pregnancy history, again, this is for both the male and the female partners. And have you or your spouse established any previous pregnancies with your current partner or previous partners, and how long did it take to conceive? And has your partner had repeated miscarriages? In terms of childhood diseases, we want to know about any childhood diseases that can affect the testis. One is undescended testes, also known as cryptorchidism. This has shown to have low sperm counts and decrease even sperm precursors as early as less than a year. Hernia repairs, mumps, testicular torsion. Testicular torsion is twisting of the testicle. This can happen in the childhood years to teens, sometimes into the 20s, and also severe trauma to the testicle. It's important to note that one-sided or unilateral testicular issues can have bilateral effects. We particularly see this with testicular torsion sometimes. Other past medical or surgical histories that are important: high fevers or debilitating illnesses can prevent sperm production. Infections of the epididymis, which is the crescent-shaped organ around the testicle where the sperm are stored, or the testicle. Pelvic or spinal cord injury or surgery that's affecting erections or ejaculation. Hernia repair with mesh, occasionally mesh from hernias can cause obstruction of the vas deferens, which is the tube that runs away from the testicle that brings sperm into the ejaculatory ducts. So patients with low testosterone therapy, it's important to note because testosterone actually will decrease sperm counts, and then chemotherapy and radiation therapy. So this picture is a very good picture showing the vas deferens, which carries the sperm out from the testicle and epididymis inside the body, and there's the hernia mesh, which is obstructing the path of the vas deferens carrying sperm. So it's important to know a list of current medications. There's an exhaustive list of medications that can affect fertility. However, some more well-known ones are Propecia, which is used for male pattern baldness, and then certain long-term antibiotics, other medications that can affect sexual function as well. I also want to know, has another physician already treated you for your infertility? There are medications that are actually safe for sperm and that will raise testosterone levels naturally, and these are clomiphene citrate, HCG, and anastrozole. And again, are you receiving treatment for low testosterone, erectile dysfunction, or ejaculatory issues, and then the use of fertility supplements? There are some common malignancies requiring chemotherapy, often in the reproductive years, such as testicular cancer, Hodgkin's disease, or other types of lymphoma. And what we know is that recovery is dose and agent dependent. So what I do with patients who need chemotherapy is I recommend sperm banking prior to chemotherapy. And of course, this depends on age and other social factors. Patients should not try to conceive for about 1 year after chemotherapy or even some forms of pelvic radiation. And in this study by Chan, there were 20 testicular sperm extraction procedures in 17 patients. The patients who received chemotherapy and also were azoospermic, meaning they had no sperm, but he was able to retrieve sperm in 45% of patients. There are health hazards in the workplace, such as solvents, pesticides, radiation, and direct heat. And I believe we're on to poll question number 3.
Yes, about to launch poll number 3.
So which of the following factors affect male fertility? Obesity, alcohol, vaping, or all of the above?
I'm going to close the polling now so we can see the results.
Well, we've got a smart group.
Oh, yes, we do.
So in terms of age, what we know is there's really no universal definition on what is advanced paternal age. We do know there are studies showing that as men age, there are certain molecular mechanisms that can affect sperm production as well as sperm quality and the ability to achieve a natural pregnancy. Even actually success rates with assisted reproductive technology. Now, obesity, tobacco, and alcohol can lower sperm counts, as can marijuana, even vaping. We know that vaping with nicotine and THC can lower sperm counts, hyperthermia, and cell phones and electromagnetic waves. So the lead underpants may present an alternative strategy, but could I just suggest you use your phone less? Now, this is meant to be tongue-in-cheek. However, there are some studies which do suggest that the electromagnetic waves can decrease sperm production, albeit mostly in animal studies, but there are far more studies suggesting that this isn't really a factor, and if there is, it's a very minor factor. So supplements. Beware of the internet and male enhancement supplements, particularly workout supplements that have unknown ingredients. Some are tainted with testosterone, which will lower sperm counts. The internet ads are not regulated by the government, and supplements are not regulated by the FDA. In terms of fertility supplements, I always tell patients they may help, they're not going to hurt. There are antioxidants in them. They have L-carnitine, which may increase sperm motility. And there are some studies that suggest that they help, and there are some studies that suggest that they don't. But again, may help, won't hurt. For physical examination, I start with a general exam. I often do look for gynecomastia or breast swelling. In terms of the genitalia, we look at the urethral meatus and its position to make sure that the semen deposition occurs in the appropriate location of the vagina. The testes, I look for size and consistency. The vas deferens, I want to make sure it is present. And again, that's the tube that carries the sperm out from the testis and epididymis into the ejaculatory ducts, and then also varicoceles. So varicoceles are the most common cause in men of low sperm count and motility. And what these are varicose veins of the spermatic cord, which is the cord that brings the blood vessels and the vas deferens to and from the testicle. Incompetent valves can allow blood to flow backwards towards the testicle instead of outwards, and thought to cause issues in semen parameters through a thermal effect. About 15% of men in the general population have varicoceles, but a higher proportion of men in the infertile population have varicoceles, up to 37%. And who will have fertility issues and why is unknown. However, this often is reflected in the semen analysis, as I said, motility and count, and sometimes in IVF failures. So it really requires a good ultrasonographer to determine what's a varicocele. Many ultrasonographers will say any vessel greater than 3 millimeters in diameter is a varicocele. However, this is not true. It also requires reversal of flow. So when a man bears down, or valsalvas as we call it, as you may see when somebody's doing crunches or working out, we need to see reversal of flow. Instead of the blood flowing out of the testicle, it flows backwards. And that's what we're seeing in this picture. So let's move on to the semen analysis. What's normal or average? What is adequate for pregnancy? Well, I suspect that many during COVID have not had sex for a while. And so hopefully now your sperm look like those on the left and not necessarily those on the right. Now, what does it take to get pregnant? It takes one strong, straight, fast swimmer. According to the World Health Organization, in 2010, the following limits of adequacy for a semen analysis are ejaculate volumes greater than 1.5 milliliters, a sperm density greater than 15 million per milliliter, motility greater than 40%. Again, we like to see them progressive, moving fast and straight, and then strict morphology, which is a strict criteria of shape, greater than 4%. And we do not want to see pyospermia or infections of the semen. For an initial laboratory evaluation of a man coming to me without a semen analysis, I will get 2 hormones. One is the testosterone, which is the male sex hormone. The other is FSH, which is a hormone in the brain that stimulates sperm production in the testes. Now, depending on the semen analysis results, I may get other hormones such as estradiol, which is estrogen levels, LH, prolactin, and thyroid stimulating hormones from the pituitary, which can affect sperm production and testosterone production in the testes. And some men need genetic testing for various reasons, as I'll go into. In terms of tests of sperm function, really what we're looking at is, can the sperm get into the egg? And that's the bottom line. Now, this just tells you a little bit about strict morphology. People always ask about it. And so essentially, Kruger, about 30 years ago, designed this very strict criteria of what is normal and abnormal shape in order to predict IVF outcomes. And if less than 4% were normal, that's considered abnormal, and there was less success in IVF. So it begs a question in this day and age, does strict morphology really matter? You know, the techniques have changed a little bit over time. There is some inter-observer variability. And the effects of abnormal strict morphology on natural conception in IUI or IVF is a little bit controversial. There are multiple studies suggesting that there is no effect or may not be as great as thought. There are studies of men giving semen samples prior to vasectomy that show many of these men have isolated low strict morphology. However, there's also a large body of literature related to IUI or IVF suggesting that it definitely does matter. So when should genetic testing be offered and what types? So when a man has problems producing sperm, meaning less than 5 million sperm, and again, 15 million above would be normal, we get a karyotype, which is the number of chromosomes. We like to see 46 chromosomes, an X and a Y, which is the male chromosome. We also look at the Y chromosome microdeletion analysis, looking for any gene deletions in the male Y chromosome. Now, CFTR testing is a testing to rule out cystic fibrosis mutation carriers, and this is done in patients who are suspected to have an obstruction, such as those that I cannot feel a vas deferens on. Now, those patients do generally produce sperm, it just can't get out. And other testing, such as DNA fragmentation, may be used when a partner has recurrent miscarriages or when there's just poor embryo progression in IVF. So let's look at some treatments. We'll look at medical therapy, surgical therapy, and special cases, particularly ejaculatory duct obstruction with cysts. Spinal cord injury I'll save for another day because it's very long and complex discussion. But medications, these are all protective of the testes. They stimulate natural testosterone production. So anastrozole or Arimidex, it prevents the conversion of testosterone to estradiol, which normally occurs in the fatty tissues of the body. This is sometimes helpful in obese men in order to increase testosterone, which is going to improve the environment for sperm to grow in the testis. Clomiphene citrate or Clomid is used in patients with symptomatic low testosterone, and it also can improve sperm counts and motility. Sometimes we use it empirically, meaning even in men with normal sperm counts, we try it to see if it might boost the sperm counts. When I say normal testosterone levels, we might use it to boost sperm counts. Now, HCG is typically used for patients who have symptomatic low testosterone and previously were on testosterone replacement therapy. In particular, patients on testosterone injection therapy. HCG will provide higher testosterone levels than will clomiphene citrate, and so it provides more symptomatic relief as would be seen with testosterone pellets or testosterone injections. Now, when a patient is on testosterone injection therapy, we need to reverse that and re-stimulate the pituitary gland in order to produce the FSH needed to produce sperm. And so we give HCG often and wait 3 to 6 months because the time it takes for a sperm to grow and get out of the body is 3 months. So it usually takes 1 or 2 sperm cycles to see this happen. Surgical therapy would include microsurgical varicocelectomy, transurethral resection of the ejaculatory duct, vasectomy reversal, and sperm retrieval for obstruction or inadequate production of sperm. So this is a good slide. It looks at the male reproductive tract. The testes are here. This crescent-shaped organ around the testicle is the epididymis. That's where the sperm mature and are stored. And then they come out into the vas deferens. You can see the vas deferens here. It's lit up by contrast. It comes from the outside of the body to the inside of the body. And then the sperm from the vas deferens meets the semen from the seminal vesicles, which then goes into a common ejaculatory duct. And some men get cysts in this ejaculatory duct, which would cause low low semen volume, as well as poor counts and motility. So this study of microsurgical varicocelectomy shows that a greater than 50% increase in total motile sperm count was seen in 271 patients, and an overall spontaneous pregnancy rate of 36.6% was achieved after varicocelectomy, with a mean time to conception of 7 months. We do know that men with normal FSHs, which would indicate normal sperm production or the ability to produce sperm normally, and men with the largest varicoceles do have the best success rates after varicocelectomy. In the study of preoperative IVF and ICSI candidates, 31% became IUI candidates. Of the IUI candidates, 42% gained the potential for spontaneous pregnancy. So varicocelectomy has a significant potential to downstage or shift the level of assisted reproductive technology needed to bypass male factor infertility, as well as help some couples achieve natural conception. So this slide is depicting the transurethral resection of the ejaculatory duct that I described for the ejaculatory duct cyst. So if somebody has a cyst blocking the ejaculatory duct and the semen can't get out, we generally just shave off the ejaculatory duct in a procedure through the urethra. Now, it's not such a common procedure and the outcomes aren't so great. It would improve sperm density and motility in about 65% of patients, increase ejaculate volume in 29% of patients, and initiate a natural pregnancy in 30% of patients. Now, patients who are asymptomatic from the ejaculatory duct cyst, meaning no pain with ejaculation, many couples might opt actually for sperm retrieval if necessary with in vitro fertilization. Vasectomy reversal, we can see up to a 90-95% successful return of sperm to the ejaculate and a 75% pregnancy rate. This is in a select population of men, generally who have had vasectomies within 5 years of reversal. The success of a vasectomy reversal is directly correlated with the findings at the time of surgery and the quality of fluid in the vas, the number of years since the vasectomy, as well as, most importantly, the skill of the surgeon. If this is something you're considering, you want to seek out a fellowship-trained microsurgeon. And this is a couple's decision with many factors to consider regarding whether to do vasectomy reversal or sperm retrieval with IVF and ICSI. There's a lot of acronyms for the sperm retrieval techniques, and I will just divide these into obstructive azoospermia, meaning a man is producing sperm, but it's not getting out because there's an obstruction, or non-obstructive azoospermia, meaning there's a lack of production. So in terms of obstructive azoospermia, meaning the sperm is being produced, most commonly performed are aspirations of the epididymis, where we just put a needle into that epididymis and aspirate some fluid, and then it gets frozen for future use in IVF. For patients who are missing their vas deferens, we do the aspirations as well. For people with other obstructions, sometimes we do testicular sperm extractions, which is essentially a testis biopsy. For patients with production issues, we typically do testicular sperm extractions, again, a testis biopsy, or something called microdissection testicular sperm extraction, which I'll explain in a second. So a microdissection testicular sperm extraction is definitely more involved. It takes a lot more time. And essentially what we do is we open up the testis and we're looking for plump tubules that might have some sperm production, as we see in the bottom right here. Schlegel, who pioneered this, has shown that microdissection improves sperm retrieval rates over regular testicular sperm extractions by about 15%. And the samples yield 2.5 times more sperm in about 1% of the amount of tissue taken. And the outcomes do depend on testicular pathology, and sperm can even be obtained from biopsies in patients with genetic abnormalities such as Klinefelter syndrome. So what we need is coordination with the reproductive endocrinologist. For a man, it's important to get referrals for unexplained infertility, abnormal semen parameters, and suspicion based on history. We do elective retrievals for men with obstructive azoospermia, for example, from a vasectomy, with freezing of the sperm for future use in IVF. We also do elective testicular biopsies to rule out an obstruction, or sperm retrievals, or the microdissection, which definitely requires careful coordination because we typically like the sperm to be fresh, so that they don't basically degrade or die off between the time of retrieval and the time of IVF. So in summary, of course, I recommend a dedicated male infertility evaluation for careful coordination with the reproductive endocrinologist. It should be a couples-based approach. The surgical treatments often involve microsurgery for optimal results, and this coordination with the understanding of techniques and treatments available for the infertile male will optimize fertility results. Thank you. Thank you for having me this evening.
Thank you very much, Dr. Fenig, for that wonderful expose. At this point in time, we can ask for anybody who has questions before we talk about how we can coordinate with a reproductive endocrinologist working along with a urologist trained in fertility to help couples achieve questions. Are there any questions? Okay. So while we're waiting for that, Dr. Fenig, I think one of the things that patients always ask is when the issues revolve around the partner, the husband, and we're trying to coordinate when we're trying to do IVF to collect eggs, we're trying to coordinate when we can get the eggs along with when the sperm can be obtained. But I think that depends on what amount of sperm you anticipate. Can you talk a little bit about that timing that's critical, that seems to confuse patients?
Well, I think, well, first of all, we have each other's cell phone numbers, so
That's right.
that enables coordination. But, like I said, with the obstructive patients, for the men, say, who've had vasectomies that we're trying to extract sperm, we know they have sperm. And so we can just coordinate, obviously, with the office and then freeze the sperm, and you use that later for IVF. Now, definitely is more challenging for the patients who have non-obstructive azoospermia, meaning a production problem. And again, that does require coordination because when you do your egg retrieval and when I do my sperm retrieval is critical. And we do like to have fresh sperm for those types of situations because we know that the fresh sperm in the patients with production issues are going to be the best sperm. And typically freezing those sperm and then unfreezing them, many of them don't survive the thaw. And so it's suboptimal to really freeze sperm that aren't ideal.
And then we have a question here that says, how can high testosterone decrease sperm count? I guess most people think increased testosterone should increase sperm. So how can a high testosterone level decrease sperm count?
Right. So the question is the testosterone coming from you, and are we boosting your natural testosterone, or is it coming externally? Now, when the testosterone is given externally, say by testosterone injection, what happens is there's a whole feedback loop, and I didn't include this slide because it seemed a little too academic, but basically the testosterone feedbacks on the pituitary gland in the brain, less FSH hormone gets released, and so less FSH hormone will stimulate the testicles, so the sperm are not being produced. Now, if I stimulate you with, say, clomiphene citrate, I'm actually stimulating the brain to stimulate your testicles to produce more of your own testosterone. So producing more of your own testosterone is ideal because it'll optimize the environment in the testes for the sperm to grow. But again, giving testosterone externally is going to shut the whole system down.
Okay, we have another question that says, how do patients get referred for to male infertility services?
Well, so some couples just, come off the street or read on the internet and decide that, yes, it's easiest to get the male checked out first because it just involves this basic semen analysis. But then also, like we've talked about, there's just careful coordination with the female side of things, just to make sure that the appropriate patients are being referred.
Um, I would like you to make a comment about the special case of Klinefelter syndrome, because we have a couple of patients that have this, and that news is very devastating to them, and they think it's the end of the world. And I'd like you to address that a little bit, if anything, to assure them.
Right. So Klinefelter syndrome is in part why we get karyotypes when the sperm production is less than 5 million sperm. Some men have an extra X chromosome, so instead of 46XY, they're 47XXY. And that has different manifestations in terms of not just sperm production, but other manifestations throughout the body. However, just because somebody has Klinefelter syndrome and has zero sperm in the ejaculate doesn't mean that we can't find sperm. And if you look at Peter Schlegel's data from Cornell, in terms of microdissection in Klinefelter's patients, a good number of them will have sperm production in the testes. It's less than 50%, but we can find it. And so it does not mean that you can't use your own sperm. Now, I always have these patients get genetic counseling because there's, again, other factors at hand besides just, fertility. But suffice to say that there is a chance that there's sperm being produced. It's just not getting out into the ejaculate.
Great, great. So, and then there's the other issue where we have very rare sperm seen on semen analysis. In other words, we might see one out of so many spots of looking on the microscope. So it's very, very rare. So that's another special situation where coordinating with the female partner can be a little challenging. And in that case, I know in the past you've recommended that we actually go ahead and collect the eggs and actually freeze, because we have no idea if we'll get usable sperm or if we'll be able to even freeze it to get it over to the IVF lab.
Right. And obviously you would know better than me, but there have been great advances in actually freezing the eggs, which,
Yes.
5-10 years ago, we didn't do that. We would have to coordinate everything together. We would have to make sure that you were extracting the eggs the same day I was doing the sperm retrieval in order to get fresh sperm for IVF, because what we know in men who have production issues, the best sperm that we find are the fresh sperm, or sometimes you incubate them overnight. But with the ability to actually freeze and unfreeze eggs, that kind of frees up the possibility of maybe extracting on a different day and then unfreezing the eggs when we extract the sperm in order to do the ICSI.
Okay, lastly, we're about to close. I don't want to keep everyone too long, but I want you to talk a little bit about fertility preservation in cancer patients,
Right.
either in young patients, adolescent patients, or older patients, because a couple of times we get this emergency phone call, Mrs. So-and-so is about to go get chemotherapy or radiation therapy, and it's a race to get, give us a little bit of your perspective on that.
Yeah, so of course I recommend, cryopreservation of sperm at a sperm bank prior to chemotherapy. That's the ideal situation, depending on the age of the patient and other social factors. Sometimes it's just not possible because
Correct.
patients are, have new onset cancer and they're already debilitated and they just can't do it. And in those cases, unfortunately, they can't. I have in the past done testicular sperm extractions where I make a small incision and extract testicular tissue and freeze that prior to chemotherapy in men that just couldn't provide an ejaculated specimen. I think there are a couple of challenges. One is that I've gotten over the years is the teenage male. Has the patient gone through puberty, and are we pretty sure that there's going to be sperm there? And again, who's going to consent for that? That can be a challenging situation, both, just ethically as well. But also, when I was talking about the chemo agents, so when you look at, there's some agents that are very toxic to testes, some are in the middle, and some not as toxic. And I think for the testicular cancer and the Hodgkin's disease, to name a couple, the agents are kind of in the middle. So there is a chance that we get sperm back after chemotherapy. However, we never know how much sperm we're going to get back and whether we'll get to baseline. So sometimes patients can't freeze before their chemo treatments, and then we just hope that we can get something afterwards.
Do we have any further questions? If you can unshare your skin, and if there are no more questions, let me see here. Okay, so thank you so much for being here tonight. I don't really want to take anyone's time too much. I really want to thank you, Dr. Fennick. It's just wonderful collaborating with you.
Yes.
And I thank you for all your good work. Thank you, everybody. And if there are any questions that you want to ask Dr. Fennick, just send it to the email that you'll see at the end of the webinar, and I'll be sure and forward it to him. And you can also reach out to him directly or reach out to me, and we'll be sure and get your questions answered. Thank you so much.
Thanks for
Thank you,
having
Dr.
me.
Fennick.
All right. Have a good night.
Bye.